So welcome everyone to this webinar being hosted by the Reproductive Health Supplies Coalition. We're really glad that you could join us for this discussion of adaptations used to ensure contraceptive access during the COVID-19 pandemic. A couple of brief housekeeping notes. Please do feel free to introduce yourselves in the chat with your name and organization. Also, the Q&A function is available, so please do enter questions for the panelists at any time. And feel free to enter comments in the chat throughout the session as well. You will be kept muted unless you are speaking to the whole group. So thank you very much. And let's go to the next slide. And my name is Sophia Asan. I'm Senior Technical Officer with the RHSC. And I'm very pleased today to be joined by leader at In Supply Health, who was instrumental in guiding this work for us. Wanjiru Munene is Dr. Munene is a senior advisor in market development and partnership at In Supply Health. She serves as a subject matter expert and a thought leader in market development. Wanjiru is a pharmacist by training, and she holds an MBA in healthcare management. Next slide, please. And today we will be walking you through a brief background to the strategic framework of adaptations that was established by In Supply Health, and as well as looking at the individual 6 adaptation categories. We will meet our panelists and have a discussion, posing some questions pre-arranged, and then we will also be including questions that are shared from you all. And lastly, we'll very briefly look ahead. Next slide. So RHSC was pleased to engage In Supply Health several months ago to conduct an assessment of adaptation strategies used to ensure contraceptive access in the pandemic. This work was part of the COMPASS initiative for the coalition, and the work that In Supply Health conducted included a development of a strategic framework of adaptation strategies. And they explored at the level of what was being done in countries throughout sub-Saharan Africa. Next slide. Thanks. So the RHSC and John Snow Inc., or JSI, in early 2021 published a roadmap to promote more resilient supply chains and marketplaces for RH and indeed for maternal health products and really for SRH products before and after the pandemic. The work was begun in the very early stages of the pandemic, when there was so much uncertainty for all of us. The study highlighted the interdependence of supply chain operations and the devastating impact of so many disruptions that were brought about by the pandemic. Now, the COMPASS initiative was launched by RHSC and follows on from the roadmap. The COMPASS initiative identified a few key priority areas from the roadmap to focus upon with activities to further discussion, to provide for greater information for our members on the impacts of the pandemic on supply chains, but also looking towards the future on what we can do to help to support future resilience. And along with the report, which is available on the Coalition's website, we also have 6 accompanying technical briefs, one for each of the adaptation categories that was identified by the In-Supply Health team. The next slide, please. And now I'm really pleased to hand off to my colleague, Awanjiru Monene. Dr. Monene.
Great. Thank you so much, Safia. And thank you to all the participants who have made time to join us for this panel discussion as we disseminate our report this morning in some parts of the world and this afternoon in other parts of the world. So as Safia has already mentioned, In-Supply was tasked to do an assessment just looking at what COVID-19 did to RH supplies and some of the adaptations that went into alleviating some of those hurdles, bottlenecks that were introduced in the supply chain system. So this assessment included the development of a strategic framework of adaptation, which were planned and or used. So we do understand that some were planned but never implemented, and these are also documented. And some were planned and implemented to look at how to ensure access to RH supplies throughout the pandemic and beyond. We also went a step ahead looking at country-specific examples across sub-Saharan Africa, and I will speak more to the methodology in the next slide. So we started the assessment by, first of all, elucidating some of the literature and publications that we wanted to review, just looking at different partners and different programs that were being implemented and some of the strategies that they were taking to ensure some of these programs and RH supplies continue and that access continues in different parts of the world. So we did a total of 85 literature reviews, including peer-reviewed publications, program resources, reports, interactive maps, and webinar recordings that were happening during the pandemic time. So the literature review primarily focused on RH supply chains and RH programming adaptations that were being made during this pandemic period. Our initial findings showed that most of these adaptations were developed to address service delivery constraints. So we had a bit of difficulty separating these from supply chain specific adaptations since this was our key assessment request. We therefore embarked on doing key informant interviews, especially with some of the stakeholders that we had reviewed their publication or some of the stakeholders that were focused on doing RH programming in the region, SSA. Our key informant interviews kicked off in November and went through for 3 months until January 2023. We managed to interview 26 key stakeholders across 19 countries in sub-Saharan Africa. The key informants interviews really focused on challenges that were being faced by these specific stakeholders as they were doing their RH programming. We looked at 4 key sectors: global manufacturers who would provide the finished products in terms of RH commodities. We also spoke to non-governmental organizations who are very key and instrumental in ensuring RH access. We spoke to implementing partners, social marketing organizations, and also to some counterparts in the Ministry of Health across sub-Saharan Africa. Next slide, please. So looking at the framework that we developed, it had 3 key things that we identified, or 3 key things that we wanted to bring out. Next slide. We organized our findings in this framework. As I mentioned, it had 3 key levers. We looked at specific COVID-19 related challenges that were introduced because of the emergency. Some of the things that we saw is that social distancing was enforced, restricted movement was enforced by different governments, This then led to limited human resources across all sectors, and the healthcare sectors was not spared, neither was the RH programming spared. This then led to constrained budget resources as we saw resources being redirected to COVID-19 related emergency. The next lever in our strategic adaptation framework was looking at the impact of these COVID-19 related challenges to RH programs and RH supply chains. For this particular lever, we saw five key things stood out. We saw unpredictability of active pharmaceutical ingredients and FP supplies. This was mainly affecting the global manufacturers. We saw shipping delays, of course, due to the reprioritization of COVID-19 related commodities. We also saw the prioritization of RH commodities, both at the global level, country level, and also in the regions within the country. So again, COVID-19 related commodities were prioritized. Distribution for RH commodities was also deprioritized. And therefore, we saw that in some instances, RH commodities would not get either to last mile or to countries, or even to the warehouses where they needed to be so that they could be collected and made accessible. The fifth key thing that stood out in terms of impact was global and local freight disruptions. And we all saw this, given that ports were not accessible, flights were not accessible, and of course, the intricacies of getting a ship. So the next slide then, the next lever shows the key adaptations category we came up with, and this is a blown out slide showing the third level of that strategic framework. So 6 adaptations categories were developed through this assessment, through different iterations looking at the literature review, and then of course speaking to the key informant interviews. So we saw 6 key things standing out as strategies that were enacted to ensure RH supplies continued, or the bottlenecks and hurdles were removed. Policy and advocacy, financing, supply sources, digital interventions, adjusted inventory management policies and procedures, as well as modified transport options and warehousing solutions. In the next slide, I will speak to each of these adaptation categories, just giving a quick snapshot because our panelists will go more in depth as they were the key implementers of these strategies. When you looked at policy and advocacy, we did notice, and everyone could see at the outset of the pandemic, countries around the world enforced COVID-19 containment measures, which significantly harbored capacity for public and private institutions to deliver the required products and services. And this was exacerbated by the fears of spreading or contracting the virus. The RH supply chain and RH programs were not spared. In response, stakeholders, Ministry of Health, NGOs, and other RH experts employed advocacy and legislative measures to solve these supply chain challenges. We'll be hearing more from one of our panelists on some of these adaptations, illustrations. Next slide, please. When it came to financing, several changes and several strategies that were made needed to reduce the supply chain disruptions had financial consequences. So different people had to adapt in terms of finances, given that more investment, more capital, and more unplanned activities had to be enacted. So these category adaptations included several worldwide, in-country, and partner finance approaches to improve access to reproductive health supplies. And this cut across from global all the way to the last mile. Next slide. So looking at supply sources, during the pandemic, as I mentioned earlier, there was refocusing for COVID-19 resources. Priorities highlighted supply chain flaws, emphasizing the vulnerabilities that we have in RH commodities and also in industrial component supplies. Given that SSA imports almost 100% of their products. This introduced huge vulnerabilities in terms of supply sources for RH commodities. Actors in the RH supply chain adapted to reduce sourcing risks for manufacturing inputs, as well as RH finished products. We'll be hearing that from one of our global manufacturers, as well as other partners. Next slide, please. Disruptions in global supply chains resulted in both local and global logistical delays. Restricted movement disrupted regular supply chain planning activities. We saw digital innovations and interventions and various platforms being used to include ensuring that RH programs continued. Mobile apps like WhatsApp were used for reordering levels, or even in mentioning where products are available for redistribution. Next slide. The fifth adaptation category, adjusted inventory management policies and procedures, was enacted in several countries. Supply chains in countries across SSA saw delays in processing at shipping points. There were lack of logistics personnel given the restricted movement and social distancing. There was increased shipping costs because of the demand and the supply was not sufficient. This led to longer supply lead times and higher risk of stockouts for RH commodities. We saw adaptations being applied in in-country logistics. Supply chain standard operating procedures were adjusted, and we also saw supply chain management policies being relooked at to overcome some of these logistics challenges. The last adaptation category that we came up with, or we saw, was modified transport options and warehousing solutions. As I mentioned earlier, we saw congested ports and of course, COVID-19 products being prioritized. This led to significant delays. There were attempts to alleviate supply bottlenecks that necessitated that suppliers have to provide for more storage capacity, given that they had to order more than they would usually do. The supply chain actors responded by changing transportation options and using new warehousing solutions to ensure continuous availability of the service and products. Next slide. At this point, I give it back to the moderator, Safia, to bring in the panelists just to hear country-specific examples and stakeholder-specific examples, just as we had as we were doing the assessment. Thank you very much.
Thank you so much, Wanjiru, for that great introduction to the framework and the adaptation categories that your team identified so well for all of us. I will briefly introduce our esteemed panelists, and then we will begin our discussion with them. We're pleased to be joined today by Dr. Albert Ndwiga, who is a dedicated program manager within Kenya's Division of Reproductive and Maternal Health at the Ministry of Health. His impactful role encompasses overseeing the family planning program, while also serving as the Reproductive Health Commodity Manager, Chair of the National Family Planning Logistics Working Group, Secretary to the RMNCAH Products and Technology Innovations Committee, and a valued member of the National Pharmacovigilance and Post-Marketing Surveillance Technical Working Group, as well as the National Medicines and Therapeutics Committee. We are also so pleased to be joined today by Celestin Campaore. He is the Regional Project Director for DMPA-SC in the Ouagadougou Partnership countries, employed by JPIGO. Celestin is a highly skilled project manager with a wealth of experience spanning over 10 years in advocating and mobilizing support for SRH, mainly focusing on adolescents, youth, and women in West and Central Africa. Currently, as the regional lead, he oversees the implementation of DMPA-SC project activities across the 8 countries of the Ouagadougou Partnership. And before joining JPIGO, Celestin served as a senior regional program manager at Pathfinder, where he played a pivotal role in an advocacy project centered around SRHR and the domestication of the Maputo Protocol. We are also so pleased to be joined by Willis Ogutu. Willis is the Institutional Health Supply Partnership Manager for Bayer. Willis is responsible for overseeing the corporation's public sector contraceptive business and coordinating Bayer's sustainability commitment to ensure that by 2030, 100 million women in low and middle income countries will have access to modern contraception. As a representative of Bayer, Willis actively participates in family planning technical working groups and committees of experts across multiple countries in sub-Saharan Africa. Drawing on his extensive background of over 15 years, he has garnered comprehensive experience across both the public and the private sectors. And lastly, but certainly not least, we are so pleased to be joined by Timothy Wambuku, who brings us over 8 years of invaluable experience as the Senior Manager of National Sales at Population Services Kenya, where he oversees the sales and distribution of a wide range of socially marketed RH products, including the Femiplan range, Femiject, and Trust condoms. Before his current role, Timothy held progressive positions within GlaxoSmithKline, where he made significant contributions in sales and marketing for pharmaceutical and consumer healthcare products, both in Kenya as well as across East Africa, including the Indian Ocean Islands. So we're really pleased to be joined by these esteemed panelists, and we'll now move into the discussion. The first question will be posed to Dr. Albert Ndwiga. Dr. Ndwiga, in the report that was produced by In Supply Health, we hear from a number of partners about policy advocacy successes that occurred during the early days of the pandemic and that facilitated continued access to vital RH products. These successes included budget shifts to balance RH with COVID-19 financial needs, reclassifying personnel as essential, and opening new channels of delivery where that was possible. And in a number of cases, we saw that these adaptations did become institutionalized. Can you please share some reflections on how some of these adaptations became permanent policy changes in your experience?
Yeah, thank you. For a moment there, I thought you were the one to unmute. Hello, everyone. Thank you for that question. As we all know, 2020 came with a lot of challenges. At the beginning, there were rumors of a disease that was killing people in China. And then it hit home soon after that. And we had cases reported in hospitals. And this was met with a lot of mystery, a lot of apprehension, a bit of stigma, even at the community level. And we knew that the productive maternal newborn health services had to continue. And therefore, between March and April of 2020, the division of reproductive and maternal health embarked on an emergency development of Kenya COVID-19 reproductive maternal newborn health guidelines, which were devised to help continue services in the pandemic. This was necessary because our main outlet for family planning services are public health facilities. And that is where most people fear to go because most of the cases that were reported and a lot of quarantine that were done were associated with the public health hospitals. So in a nutshell, in the FP section of that guideline, we recommended a few things to be undertaken. First of all, we reminded all our healthcare workers that family planning is an essential service and had to continue. And in addition to the WHO recommendations for prevention of transmission of COVID-19, such as wearing of face masks, wearing of gloves, sanitizing, and hand washing, we asked our healthcare workers to take some questions. One, to recommend methods, family planning methods that do not require prolonged client-provider interaction, such as IUDs. And for the people coming for initiation of family planning, the recommendation was that we do methods that are easier to use, that do not require a lot of interaction, such as pills and condoms. And luckily, we had very huge quantities in the country of the combined oral contraceptives at the time, coincidentally. And therefore, that plan worked very well. In fact, the consumption of COC climbed steadily between 2020 and 2022. We also recommended staggered return dates to ensure there's no crowding in the outpatients and FP clinics. People were able also to do appointments by phone, and the family planning service was extended to 24 hours, again, to reduce the crowding. That guideline was the quickest guideline in history that we've ever made, and it was disseminated also very quickly. And you may have noted that a lot of resources, domestic resources, went into the war against COVID. There was a lot of research that was being done. There were a lot of commodities to be bought, personal protection equipment, sanitizers in very unprecedented quantities. We were buying a lot of disinfectants and so on. And therefore, the domestic financing for family planning reduced. And that is the reason why the 2019 MOU between the Ministry of Health and the major donors in FP, such as BMGF, USAID, FCDO, was revisited. And this time we were determined to have it signed, and indeed it was signed later in the year. And though the original MOU was to expire in 2024 financial year, we were able to negotiate an extension to 2025-2026 financial year because of the constraints that were brought about by COVID. We also realized that we were ill prepared for COVID and as such a pandemic. And therefore, there were other things that I guess arose from there. We started speaking to each other about the best way to ensure services continue in the future in the case of such emergencies. And that is why we decided to complete and implement the total market approach strategy for family planning, which gives responsibilities to other market segments beside the public health system to offer family planning services, which will be important in cushioning the nation in such an eventuality, because there will be many outlets for this service. We also put in motion the development of family planning self-care guidelines, which are being completed this week and will be launched. And the reason for this is that we realize there are a lot of things that the clients can do for themselves without necessarily having to go see a doctor or go to a health facility. And those ones are in a self-care guideline to empower the clients to, take some services by themselves and reduce the frequency in which they are required at the health facility. And of course, we also require to do something about the perennial menace of stocks out. And one of the interventions we did in that area was to partner with our supplies authority, KEMSA, to come up with an integrated logistic management information system that includes a commodity early warning and alert system, that includes a proof of delivery, an electronic proof of delivery, to ensure that the supply chain is efficient and we are not losing any items to inefficiency. And this has helped us a lot, and I can see the effects have already started being felt. And going forward, we are going to continue putting other measures in place to ensure that services for family planning will always continue. So thank you very much.
Thank you so much, Dr. Ndwika. We really appreciate your insights today. And I'm now pleased to move on to direct a question for Celestine Campaore. One important lesson that the pandemic highlighted for all of us was how deeply interconnected we are across the globe. Challenges related to financing and supply sourcing underscored the importance of considering global markets, global funders, and international and regional collaborations. The West African Health Organization, WAHO, which brings together stakeholders across West Africa outside of emergency situations, activated in the early stages of the pandemic to support markets, ministries, and funders in the region in getting commodities to clients. Can you kindly share 2 or 3 elements of WAHO's regional approach to ensuring that RH products were accessible throughout the pandemic?
Okay, thank you so much, Sophia, for this question. I think one of the lesson we are learned during this the pandemic of the COVID-19 is the interconnection with all stakeholders, and how we can continue to offer the services for women access for the health during the COVID-19 pandemic. For example, with the West Africa Health Organization, it is the organization with the ECOWAS. The West Africa during this pandemic, when the pandemic started, the West Africa make more activities to be sure they continue the coordination with the countries can support the women access for the services. The one example is the development and adoption by the ECOWAS Assembly of Ministries of Health of the Strategic Plan for Institutional Communication and Procedure Manual. That's one. Another thing I can add is the establishment by the 15 countries of the National Public Health Institute in charge of the coordination of the COVID-19 in the countries. Another thing is the development of the regional strategic plan for the COVID-19 response. That is another thing I can add. The 3 key activities the ECOWAS made during the COVID-19 pandemic. Another thing is continue to work during this pandemic. The ECOWAS work with the Ministry of Health closely to support them, to discuss with the Ministry of Health, to share the country's experience, country by country, in how to get the best response for the COVID-19. And for example, we have the organization of the weekly meeting with the director of the National Public Health Institute of the 15 countries during the COVID-19 pandemic. They will all do this. Another thing is, for example, the training of laboratory technicians in the diagnostic process. That is another action, key action the ECOWAS developed during the COVID-19 pandemic. And another thing I will add is the interconnection with the ECOWAS and the Ouagadougou Partnership coordination, and to pushing the countries to make the discussion, continue the discussion with the donor and each actor which working on the West Africa to know how can continue to pushing the women access of the services during the pandemic, how we will continue to fund better concerning the supply, concerning the reproductive health in general in West Africa. That is the example I can give regarding the ECOWAS area, regarding the West Africa, specifically the WAO met during the COVID-19 pandemic. Thank you.
Thank you so much, Celeste, and we really appreciate this very informative update and overview from you regarding what took place in the Wahoo region. And thank you. And now we're pleased to move on to direct a question to Willis Ogutu. And Willis, of course, Bayer is a world leader in reproductive health manufacturing and also manages their distribution in close to 150 countries. Bayer's clients, including governments, multinationals, SMOs, and also includes, to some extent, technical partners to MOHs. Could you kindly paint for us a picture of what the pandemic did in terms of RH supplies from Bayer's perspective, and how the company was able to re-strategize some operations and plans, specifically in the sub-Saharan African region? We look forward to hearing you share any actions or adaptations that you were implementing or that you saw being implemented by your colleagues, along with ideas around what it took to implement and who key stakeholders were. So thank you, Willis.
Thank you very much, Safia, for the opportunity. So first, I will start by just mentioning Bayer is a pharmaceutical company in the business of manufacturing and also distribution of contraceptives and other products. So some of our partners usually include the Ministry of Health and Social Marketing organizations within the low middle income countries. And majority of these countries usually are in this region of sub-Saharan Africa. So on a regular basis, business as usual, already that gives you an impression of magnitude of the logistics. It comes to supply chain, transportation, and also warehousing that is required to execute such a mission. So here we come during COVID. Bayer gives a commitment, a global commitment, to make sure that we will in 10 years reach 100 million women and new users with modern contraceptive methods. And so when the period of COVID came, it was just 1 year after beginning this implementation. So the biggest hurdles that we had were first, when it comes to the manufacturing bit. So we rely a lot on the raw materials, manufacturing raw materials from suppliers. And these suppliers are across the continent, from China to Asia to Europe. And it became a big issue because without raw materials, we were not able to execute our production. To the restriction in regards to human resource also created a big challenge for us. For us to supply the globe, it means we have to continue manufacturing on a 24-hour basis. And throughout, our production units will be closed maybe in a month, within a year. So then we have this issue of now warehousing. So what happened is that we had to really sit down and reevaluate our commitments, because we usually manufacture on contract. So we had to renegotiate with the suppliers of raw materials to sort of cushion the price effect, and also to be able to reschedule our productions and orders. We had to shift some of our human resource from our other production units and sites, as well as arrange for some transportation. Yeah, then finally, when it comes to the manufacturing bit, we had to also make sure that our warehousing and inventory was within an acceptable limit. So all these happen in our production sites, in Finland, where we produce the implant, as well as in Germany, where we produce the pills, among other sites. So the logistics bit was the big challenge. One is because we could no longer get cargo flights. And if we got the cargo flights, then they will give us lead times of 4 months. Ordinarily, our lead time for deliveries are usually 12 to 8 weeks, 8 to 12 weeks. And so then it meant that we had to talk to the governments, sit down and review our contracts. And it was quite an agile kind of discussion where constant communication, weekly briefs happened. I remember we had some deliveries in Kenya during that time. And so we really had to make sure that in line with our promises, that products were delivered on time. And then we also had this issue of the cost. The cost was the biggest issue, because everybody was increasing costs as a result of course, all the different aspects during COVID. We had also to talk to our logistics colleagues, for example, insurance, DHL, who we work with hand in hand globally, as well as people like the airlines, who already had an issue with cargo flights. Then I will also want to touch on the issue of digital issues, digital innovation. After COVID, we embraced the digital innovation to be a key component that will help us achieve our strategic kind of focus. Of course, our mission being health for all, hunger for none. So to the extent that we have deliberately scouted and looked for partners with digital expertise, as we come in with our expertise on the pharma, to reach out to the general population in terms of access issues and social marketing of our products. So we have, for example, Zuri Health, who we recently joined partner with in Africa in selected countries to help us execute this mandate. We also have some digital innovation like Life Yangu that we launched in Kenya to sort of create a bridge between where to get the services, contraceptive commodities, as well as the process of just reaching out to people for counseling and also guiding. So I can tell you that the inventory was a big issue, and so we had to also sit down and redesign our inventory kind of management so that we are able to serve everybody, so that not one person gets or one country gets much more than or at the expense of another. I would like to stop at that, and thank you very much, Sophia.
Thank you very much, Willis, for that very informative overview from a major pharmaceutical manufacturer. Thank you so much. And now I'm very pleased to direct a question to Timothy Wambugu. So Timothy, throughout the pandemic, of course, supply chains were being stretched, and consumers across the globe had troubles accessing all types of products, from hand sanitizers to toilet paper in the United States, and of course, all types of shortages, including PPE across the globe. In the report produced by InSupply Health, there's a robust section that details some specific warehousing, transport, and planning challenges that impacted RH access. Can you kindly summarize for the audience some of those challenges from your perspective and share how your team addressed them for both your public and your private sector markets?
Thank you, Sophia, for that opportunity. And PS Kenya is a healthcare NGO assisting the government of Kenya in addressing shortcomings in the health sector. I will sum up the challenges that we faced during the pandemic into three categories. We had manufacturing challenges, supply, shipping and freight challenges, and also warehousing and distribution challenges. If I may just elaborate on each of those challenges, we faced, for the manufacturing challenges, we faced factory closures. We get our commodities mainly from India and Indonesia. So I remember a case where we had a factory in Kerala, India, which closed due to a COVID outbreak. And we had to enlist a new supplier for condoms. That was, in a nutshell, just supposed to mitigate the closure of that factory. So we got a new supplier enlisted, and they were able to take up the orders that were pending. In terms of shipping and freight challenges, we saw port delays, there was lack of shipping containers, vessels themselves. So we had to actually increase our forecasts for whatever was available at the RH commodities. We had to double our forecasts. And in some instances, we also had to reroute our main shipping lines, focusing on longer routes that were much faster. For example, we had to abandon the southern India Colombo route, which was experiencing massive delays during the pandemic, and opted to use the India, Singapore, Mombasa route. So that was also geared towards making our RH commodities available. In terms of warehousing and distribution, because of the increased forecast that we had, because we had to double our forecast, we had to take up extra warehousing space, and that came at a cost. We took up the extra cost within our P&L. We didn't increase the price of the commodities to the end user. So again, we also linked up with our distributors, because as well as PS Kenya itself increasing the share, the warehouse space, we also required our distributors to also double their capacity. And we had to also increase their credit limits to accommodate those increased forecasts. So in a nutshell, those are some of the mitigation plans that we had to ensure that RH products were available within the market. Thank you.
Thank you very much, Timothy. And I believe, let me see, yes, and have a question just came through, and please, others, please do feel free to enter your questions. And I'll read this question, and it'll be available for whichever of the panelists would like to respond. So during COVID, when financial resources were being incredibly limited, what did panelists find to be an effective advocacy approach in encouraging decision makers to prioritize funding for RH supplies? Were there specific strategies that you found to be most effective? And who would like to take that question?
Me, I can start, probably another panelist can complete. During the pandemic, we know that more of the government make the focus for the COVID-19. And there at the moment, the budgets, the family planning budget or the sexual reproductive budget, more of the country try to reduce this. During this pandemic, in Burkina Faso, for example, we will make more discussion with Minister of Health to discuss, to advocate, to tell them that we know that we are in the context of the COVID-19, but it's not necessary to reduce anything concerning the family planning, reproductive health in general. And we're pushing the government to continue to talk with the manufacturing to be sure during this pandemic, we continue to get the product, pills, preservative, etc. during this pandemic. That is another thing. In the regional, we developed the regional approach to talk with the government with using the World Partnership Platform, using the ECOWAX platform, using the WOW platform to talk with Minister of Health, to advocate, to continue to fund and to continue to increase the budget concerning the family planning, concerning the sexual reproductive health in general, but not necessarily to reduce, because during this pandemic, more of the countries make the focus and try to reduce the budget, to review the budget concerning the family plan. That's one example I can share. Thank you.
Thank you very much, Celestin. And because we have received 3 more questions so far, I'll go ahead and move on unless someone else wants to chime in. The next question is, thanking you for the insights that you've shared regarding adaptations. And curious to know whether you have seen the prices decline, or are prices still higher than they were during the pandemic? Has that led to continued issues with financing and supplies? So who would like to take a shot at that?
Yeah, I think that question comes in two folds, one from the manufacturing perspective and also two from the SMOs who eventually transfer the price downwards to the end user. So from our end, as I told you, our model is a sort of a social business model. And our aim is basically to provide access to contraceptives to the end user at the most convenient and pricing. So our pricing models require that we do contracting for a very long time, so long-term contracting. And so by that, we're able to control. And 2 is that there are exceptions that we have to adhere to. And so it means even if the prices will change, it will take maybe another 2-3 years for that to happen. So thanks God, a product like Jadel implant was $8.5 then, and it's still $8.5 up to now. And the same applies to all our commodities. But then we have to appreciate that there were some instances where we had to increase the prices based on the logistics. And so after the COVID or post-COVID, then definitely the prices will come to a normal level. And so we continued with those pricings. So to answer you from a manufacturing perspective, specifically from buyer, the prices, we cushioned ourselves and the end user to the extent that the prices never changed. Thank you.
Thank you, Willis. Did anyone else want to respond to that question?
Sorry, it's Albert here, and price changes, are relative. What we should be asking is, what was the effect of COVID-19 on the economy? Because we've seen a lot of local currencies plummet. All contraceptives are bought against the dollar. So the truth is, looking at that inflation, the prices changed. They went up. So much so that we've had to reduce the quantities of items we had, proposed to buy in just a few months ago. So it's not looking good because most of the economies were hit very hard by COVID-19. Businesses were closed. People were not going to work. Economy stopped generating wealth. And therefore, the prices of everything, including fuel, went up. And it has been a very significant jump in the increase in the prices of contraceptives, which has become very difficult even to absorb. So the answer is yes, the prices of everything, including contraceptives, non-pharmaceuticals, medical equipment, relative to our economy, has in fact gone up.
Thank you very much, Dr. Ndwiga.
Safia, this is
Yes.
Timothy.
Yes.
Yeah, for the socially marketed products, and which we charge at an affordable price, we endeavored in terms of trying to just maintain a small margin that would allow us to meet the cost of operations and not passing the increased costs to the end user. So during the pandemic, we struggled so much in terms of just maintaining our normal prices. But this again has changed because of the fluctuations of currency, like Dr. stated. Yeah, thank you.
Thank you so much. And because we have received a few more questions and comments, I'll go ahead and continue. Someone else expressing thanks for the informative discussion from our panelists and asking, what was the biggest lesson from your perspective learned for moving forward? And who would like to respond regarding a big lesson that was learned?
Thank you. Okay.
Sorry. Yes, I can go ahead. Let me take up the lessons that we learned, particularly for socially marketed products, that disruptions within the supply chain can be really unpredictable. They can happen at any time. And businesses have to be, and organizations have to be flexible in terms of their processes, in terms of agility, to be able to factor in some of these disruptions. There's always, you'll always get it right when you increase your buffer stock a little bit. It might be an extra cost to the business, but you don't know when these disruptions occur. So I think the biggest lesson we learned is also have extra backup plans for factories that can supply you in terms of lockdowns, and also have plans that you can be able to flex within a short time. Thank you.
Thank you very much. And we can continue on and back to regarding the responses that our panelists offered regarding pricing. Jason Bremner responds, thanks for those comments, and good to hear that commodity prices have been the same. But it seems the logistics factors, shipping, gasoline, and other fees will be affecting availability of financing. For supply chains. So I guess that was more of a comment, and I think that some of you also responded to advise that, yes, as I think many of us saw, that depending on the products, depending on the market sector, unfortunately there were indeed price increases.
Yeah, just to add on, Sophia,
Yes.
if you allow me a second, the logistics is a big issue when it comes to the supply chain. I give you an example. Last week, I ordered a book from France, and the cost of the book was £50, but the logistics to bring it to Nairobi was £25, £250 by UPS, and £150 by DHL. 3 or 4 times the cost of the commodity. And that already gives you an impression of how big an issue the supply chain is when it comes to the logistics of and Dr. Ndwiga has already mentioned the dollar right now is crazy. We are heading to 140 US dollars for the Kenyan shilling. And I can tell you the contracts that we have signed within this year, I've already gotten requests. So some of the supply entities, just I don't want to mention, that can you consider us paying you through our local currency? And that already gives you an impression how even the dollar itself plays a big role when it comes to pricing of the supply chain on contraceptive commodities. Yeah, thanks.
Thank you very much. And did anyone else want to comment on that before we move on?
No, I wanted to, this is Albert, I wanted to talk about lessons learned. They say every cloud has a silver lining. There was a powerful lesson for the Ministry of Health, especially the people dealing with RAMCA, concerning disaster preparedness. It is something we thought that should be done by other people. We thought it is a docket of other government ministries and departments. But it came to our realization that being prepared is everybody's job, to an extent that now we have an emergency preparedness plan, which we will be updating every year. That was a powerful lesson for us. And we also learned to be more, to be better communicators, because we were relying on other people to bring everyone together to solve the problems that we are facing in COVID. We built bigger networks. We had better understanding of our donors. We even started talking to people who hitherto were not relating with, like the people in the Treasury and the Planning Ministry. We also started making very close connections with the National Council for Population and Development. We started making inroads to the private sector. Dr. Willie is going to be a witness to this. I think he's been more involved in family planning in the last few years than anybody has in the previous 20 years. So that was a very powerful lesson of collaboration, a powerful lesson of emergency and disaster preparedness.
Thank you so much, Dr. Ndwiga. And we have another question looking forward, building on the question about what the largest lesson was that's been learned, asking what specific actions need to be taken that can help position countries to be better prepared for a future pandemic or other localized shocks and stresses.
Well, this Albert again, I don't want to hog the conversation, but there's something that we realized during COVID-19 pandemic, that no single country is really prepared to handle a disaster of global magnitude. And it requires nations to come together and think together and see how they can handle this thing. And there has been a conversation, especially in the East African community, about pooled procurement, to take advantage of large scales of economy, to ensure that there's sustainable supply of essential medicines, and especially for commodities related to family planning. So I think that came to light, that no single nation was really prepared to handle disaster. We had to rely on other people to bring us the vaccine, for instance, and there was a huge delay before the vaccine was delivered to African countries. And the conversation was started to an extent that Kenya right now is developing an industry around vaccination. I think they're calling it a COVAX. So that is one example I can tell you that emerged from the COVID-19 pandemic.
Thank you so much, Dr. Ndwiga. That's really interesting and enlightening to hear. And we'll take one more question, which has been posed, and then we'll move on. And this question is regarding regionalization. Does regionalization of manufacturing and distribution solve some of the shipping or logistics costs and concerns, or are there more cost issues introduced if products were being manufactured within the region? Would anyone like to answer that question?
I think Ndwiga has alluded to, Dr. Ndwiga has alluded to the measures that the government has taken place, and I don't speak for the government, but he mentioned the total market approach. He mentioned the coming of the East Africa community to sort of think of a sort of a hub. I know in West Africa there is CAMEG, and I work with them a lot. So it's sort of a single procurement entity for the regional countries, French West. I think all those are aimed at bringing the costs down. But then when you talk about regionalization of manufacturing, then it boils down to a country, policies, investment, and all those aspects that are conducive for manufacturers. Rwanda is taking a very active role in embracing local manufacturing. And even our recent government who came into power recently has mentioned in several occasions that they want to promote local manufacturing, and I think those may be some of the measures that at a long run could be part of the solutions. But of course it involves all the players, right from the people who invest in terms of the manufacturers to the government, and also even the local material suppliers. So definitely this is a long shot, and it has always been there has always been an attempt by the different governments in the region to try to demystify this aspect, that if we do local manufacturing of contraceptives, then it is possible that to some extent we can have some control. But I leave it to that, because then it's not the area that I'm an expert in.
Thank you very much. That is helpful to hear. And on that note, please do feel free to have a look in the chat on your screen, as a few additional comments have been added. And now we'll go ahead and move forward, and I will hand off briefly to my colleague Wanjiru.
Thank you so much, Sophia, and thanks to all the panelists. I think we have to all agree that was quite exciting, and it was quite refreshing just to hear different perspectives, different countries' perspectives, and different regions' perspectives. So I'll spend a few minutes just speaking about looking ahead and what we could perhaps learn and what we could prepare for future emergencies. We have all seen that the challenges that impacted the delivery of RH supplies and services was diverse, and they affected everyone involved in the RH supplies and programming. Some of these challenges had the greatest impact during the onset of the pandemic, but some have persisted and even created new roadblocks and new conditions. So I would like to just speak about the key learnings and observations, and allow me to highlight that the responses to the pandemic-related challenges included the enhanced use of existing policies, procedures, systems, and technologies, in addition to the development of the new adaptations that we have discussed. While these circumstances and challenges associated with each adaptation were different, there were common themes in the successful implementation of the adaptations that emerged. So for one, when we think about policy and advocacy, or we speak about policy and advocacy, actions were taken to prioritize access to RH services. And this was critical to enable the movement of essential personnel, healthcare professionals, and also the commodities themselves. They created a condition supporting availability of RH products and services. So without these policies, some of these challenges could not have been overcome. Speaking of financing, emergencies always have an unexpected financial impact. So some of the things that we saw that really helped RH supplies continuity was pooling of resources and also co-financing. Pooling of resources unlocked access to funds and resources that were used for RH supplies and commodities, as well as RH services. This was rightly mentioned as by partners like the Ouagadougou partnerships, who supported and enhanced programs and ensured access to funds and resources throughout the pandemic. For supply sources, we've already intimated to it in our previous discussion, the issue of regional and localization of manufacturing. We have to agree that there is limitations in terms of regional RH manufacturers, which definitely disadvantage sub-Saharan Africa. A vast majority of our RH supplies are imported. We need to foster efforts for greater regional pharmaceutical manufacturing and include discussions of RH manufacturing in the current localization discussions and efforts. For digital interventions, next slide, please. They enabled great levels of data visibility and use in the pandemic. So we cannot overstate the need for data and the need for data visibility in country, across the region, and also globally. During the pandemic, data visibility across supply chain was supported, and it supported redistribution of products within countries and regions. We saw improvements in inventory management and procurement execution, and we also saw identification of alternative suppliers for RH supplies and data sharing between buyers and SMOs. For adjusted inventory management and policies and procedures, we saw these adjusted inventory levels and reorder periods, and also the redistribution of products that went very far in helping to improve RH product availability in many settings, both locally and globally. This was well documented, especially in the West African region led by West African Health Organization, as well as the Ouagadougou partnership. One key thing that has come out from this conversation, and everyone mentioned, is that collaboration across the supply chain actors, but even beyond supply chain actors, is essential for future emergencies to ensure the success of all the adaptations. Thank you very much. And I definitely encourage everyone to just look into the report. We have further reading. This is the initial report that was kickstarted in 2020-2021, right at the beginning of the pandemic. Community Roadmap for Action. I'd encourage all of us to read this as a background, and then of course proceed to read our report. We can also not overstate the importance of high impact practices that have been documented, and we've shared a link to this for further reading. Thanks very much, and do have a lovely rest of the day. Thank you. I hand it back to Sophia.
Thank you very much, Wanjiru, for that great look moving from looking backwards to looking forwards. We really appreciate that. And I want to sincerely thank the team from InSupply Health, as well as from JSI, for their invaluable leadership and thought leadership, and the work that they did in developing the strategic framework of adaptation strategies and fleshing out individual adaptation categories and down to the level of specific adaptations in countries. We really appreciate the work that they have done. And thank you all so much for attending this webinar. We do appreciate your participation. And of course, particularly, we want to thank our esteemed panelists who so kindly joined us today and shared generously of their time. For everyone, the report and the briefs are available on our website, and I believe that some links were also entered into the meeting chat today. The recording of this webinar will also be made available on our website. So thank you all so much for joining us today, and have a very nice rest of your day.
Thank you so much, Sophia. Lovely day.
Thank you. Goodbye.
Thank you so much, Sophia.